Hello, everyone, and welcome to the Ravitz Way, the podcast where we explore topics in neurology and brain health, from neuroscience to medications to wellness to news to spirituality to exercise and beyond. Let's explore the depths of the human mind and what we are capable of. There are so many podcasts to listen to these days, and everyone has an opinion. Let's try to filter through and separate the facts into undiluted truth. I'm your host, Dr. Risa Ravitz, and I'm not just your average neurologist. My interests and passions run deep, and I'm constantly pushing myself to find truth. I'm a medical doctor, a woman, a surfer, a runner, and an exerciser, and an avid reader of all topics. I feel like it's time for me to share what I have learned. It's not easy to sift through all this information. Let's see who I can meet and what questions we can explore. How can we all be healthier humans? So please, if you enjoy this show, subscribe, rate, and share with your loved ones. Let's go. Welcome to the Ravitz Way. I'm Dr. Ravitz, and I'm here today with a special guest, Luciano Rossi. He is a physical therapist, a friend, and he is extremely knowledgeable in many, many things, and I'm very excited to have you. So, Luciano, why don't you start and tell us your background?
Yeah, so first of all, very glad to be here. Talk a little bit today about quality of life, well-being, sports, physical therapy, and what the positive things. I started in physical therapy about 2003, but previously I studied international relations. I studied it for 4 years and a half, international relations, but definitely I didn't feel a passion for that subject. And I always knew that I would be better working with patients, helping people in pain, especially in sports. So I left the school, International Relations School, in 2003, started physical therapy. And at the beginning, I always was targeting be working with sports and athletes. And I have been working with a lot of them. I worked in Brazilian volleyball team, Brazilian judo team, a lot of soccer players, a lot of volleyball players, a lot of different athletes. And I came to US in 2010 that I get my license.
And you were with the Olympic team too.
The Brazilian Olympic team, the volleyball.
Wow.
So 2008, 2012. So I was part of the team that got the golden medal.
Wow.
The women team. So we got the golden medal in Beijing,
wow.
2008, and in London, 2012. 2016, I worked in the Rio Olympics, but I worked not in a team, specifically speaking, but I worked at the track and field competition. I had the opportunity to be inside the field of play and see very closely these fast people winning the gold medal, and was a great experience.
Amazing. So I'm going to be honest with all the listeners. So I actually used to be an athlete, not anywhere near this level that Luciano has been working with. And I've run into challenges with injuries like everybody else as you get older, and found Luciano through a colleague, and he's been helping me a lot with various injuries. And I also am boarded in pain management, and I've done a lot of pain management for the last over 10 to 15 years now. And one of the things we talk about a lot, and I think something we have in common is, I'm on the medicine side. I'm the doctor. I'm the person who sees the patient coming in with, a sore shoulder, a sore back, a sore neck. And I have to do imaging studies and get the medications and possibly think about something like some interventions like surgery. And I'm always sending people to physical therapists. And I think some physical therapists are extremely good. Some are very good, but are limited by, what the insurance will pay for here. And I think you and I have a very similar philosophy about pain and what that is. So I really want to share that with everybody, because I think it's really important. So let's maybe talk about my shoulder. That's one of the reasons I came to you. And it doesn't have to get too specific, but I essentially had like a frozen shoulder, right? Like that's what the MRI essentially showed. That some mild tears. I didn't require surgery, thankfully, but it was very, very hard for me to go about with my life. I couldn't lift my arm over my head. I couldn't put my backpack strap on. I couldn't swim the crawl stroke. There are things that were really limiting. So when you saw me, like, what did you think first?
So, well, I believe that as a physical therapist, my approach is a little bit different than a couple colleagues because I don't look only for the limitations of the tissue by itself. Sometimes the MRIs, the X-rays, they are showing injuries, but like our body, most of the time is able to adapt to that little injury showed by MRIs, X-rays. And as a physical therapist, what I'm looking for? I'm looking for movement. What are the limitations you have in terms of movement? I do a comprehensive evaluation. I look for limitations in terms of range of mobility, but like especially in terms of mobility, I would say, in terms of stability. And then we start to work over there. We need to improve our mobility. We need to improve our stability. And then little by little, I start to increase your capacity. So depending on the activities you want to play or to practice, I have to increase your capacity to make you able to do that. So sometimes the MRIs, X-ray is going to be showing some little tears, some limitations, but we can go beyond that.
So they are most of the time, let's be honest. So most of the time, I'm on the medicine side of things.
Mm-hmm.
We're getting scans. Let's even talk about low back scans, right? There's almost always, let's say 70% of the time, don't quote me exactly, but there's something on the scan, right? There's a bulging disc, there's an annular tear, there's maybe a quote nerve compression, maybe a spondylosis, maybe a shrinking of the space between the discs. I do thousands of these scans, and you know that. You see patients, they bring their scans, and the majority of those patients, one, don't need surgery, two, end up taking medicines that probably they need initially, when you strain something and it hurts so bad and you can't do things, but they're really limited. Like, you know what happens to their head when they come in. I mean, what do they tell you? That I felt that way. Like, I can't do this. I cannot do this. So what do you think is like the bigger picture of that?
I think like we have some guidelines. They are very interesting nowadays that show us how to deal with these images. For example, low back pain. Most of the time, you have to look for red flags. With the red flag, show us that the patients need the MRI. Okay, let's try to go deeper on their situation and try to understand better what's going on. But most of the time, you don't need MRI or picture because, like, if you take it, probably you're gonna find something
for sure.
But the images, they don't show the adaptation of the body for that condition. It shows like some change in the picture that most of the time they are normal. Because as human beings who are moving, you create some adaptations in our tissues. And these adaptations, most of the time, they are enough to prevent problems. And the pain is much beyond the body. When you talk about pain, most of the time we talk about like a biopsychosocial situation. Sometimes the body is injured and okay, let's fix the problem, like an ankle sprain. But certain conditions, depending on the time frame, it becomes much beyond of that. Sometimes you have nothing to be treating in the body by itself, but you have to show to patients that the pain is true. When they report pain, it's true, it's there, but they have to be feeling confident enough to be beyond that point.
Yeah.
Sometimes they are trying to protect him a lot.
For sure.
Yeah.
For sure.
And this protection causes like sometimes even more problems.
Yeah.
When you are confident, based on tests, of course, we have to be responsible about it. We do tests. We see that the problem is not that big as they think it is. Okay, let's go beyond that. Let's push to go beyond. And little by little, we're going to adapting this body for their condition. And little by little, the pain goes away. They're going to be feeling much better.
I can explain a little bit, and you know the science behind this too, because we talk about it. But the reason that we feel pain from an evolutionary standpoint is, a fairly simple explanation, right? Like, let's say you trip and you fracture your ankle, right? And you need to know that it's fractured, right? It needs to be immobilized for 6 weeks. and then it heals, right? So it has pain, and you shouldn't walk on it for those weeks and whatnot. And then you take the cast off, and there's still pain, right? So the pain is actually being perceived in this foot that now healed. And the pain receptors run up the leg, back through the spinal cord, and into the brain. And the brain, and I'm a neurologist too, the brain maps out an area that it's feeling, it's somaticizing, it's perceiving pain in the brain. So your actual perception of pain is not in the foot, it's in the brain and the spinal cord. The spinal cord modulates everything. So what you're talking about, what happens to people, and there's different conditions with more and less risk, but they have some sort of injury where the body's trying to tell you there's something wrong, right? It's a warning, it's a this, check it. And then it keeps going for some reason. We don't understand exactly why. There's sensitization, there's signaling that's happening. And then you continue to guard that part. And then what happens when you guard your foot and you don't walk on it for 6 months? It's a problem. It's a major problem. So for many of these pain syndromes, they talk about movement and having to do physical therapy. But these poor people are in excruciating pain. And on a smaller level, we could take it to something like the back, right? You have this horrible back spasm. I mean, you've had that pain. I've had that pain. Most patients have had thrown out their back. It's horrible pain. It's like 10 out of 10 pain. It's one of the most disabling conditions in the country. It's the reason that it's the biggest reason that people go to an ER. It's the biggest cause of disability. And it's unfortunately but a missed signal. So people are guarding. They think something horribly is horribly wrong. It isn't. A lot of people, there isn't so much going on there. And you see them, they're guarding. They won't, me too included, won't move a certain way or we're scared. So part of, I think, what's amazing that you do is you focus on those movements, stability, creating more strength and reteaching the brain, reteaching me, okay, I'm not going to have, it's okay if I have a little of this pain and then next time maybe it'll be a little less, right?
Yeah, actually, the pain is very important mechanism, or protective mechanism of our body.
Yeah.
Imagine you're cooking something and then you put your arm in the fire. If you don't have pain, you're going to burn yourself.
Exactly.
You're gonna burn bad. The point is,
but we're talking about something different, right? So for sure, that's what we need. You used to work with athletes primarily, and now you work with, quote, everyday people. So can you tell me a little bit how you transitioned into that?
Yeah. So about 2015, I opened my own clinic in Brazil. Mm-hmm. So at the beginning, I had a lot of athletes, professional and amateur athletes coming to me. And little by little, more medical doctors start to referring patients for me. At the beginning, amateur athletes, but more and more like regular people. And a lot of patients coming to me at that time with chronic situations that are completely different than athletes. Most of athletes, they have like acute injuries. And these patients, like regular people, like
and younger. So professional athletes tend to be younger. So
exactly. So
less chronic.
Completely different patients start to come to me. And definitely at that point, 2015, I started looking for evidence in terms of how to treat these chronic situations. And then since I can see more and more studies being released, more and more research in terms of chronic pain. And this is great because I have a lot of support to be providing for these clients, to these patients, the best evidence. And definitely, if you compare the evidences 10 years ago and now, we have much more support to be providing the best treatment for these patients.
So you're talking about, let's say, like a chronic pain patient. So somebody who had knee pain and let's define it, let's say more than a year or more than 6 months. I mean, the medical field sometimes says 90 days for certain things, but I would say 6 months to a year, I would categorize that.
Yeah. When I start looking for more answers for that, I became member of International Association of Study of Pain. Mm-hmm. And this association has been providing and publishing a lot of good studies, research. And then we consider patients after 3 months in pain, we can consider them as chronic patients. So the point is, when I do evaluation of my clients.
So just to interrupt you really quick, the science, I have to look into this because it's very interesting, but you start to get what's called epigenetic and not epidemiologic. You get changes at the genetic level after that time. So you basically get, you get a receptor going into something that a receptor going into another receptor signaling, that signal becomes very strong and recruits other like neurons that are either close by, and the circuit gets stronger. So it takes maybe that amount of time to start becoming a more, not permanent, I don't want to say, but a stronger circuit, right?
Yeah.
And then that's a new baseline. Okay. So when the baseline maybe had just a light connection and whatnot, then it becomes a stronger connection.
Yeah.
So, and it takes that amount of time to do that. It is really, you're changing the structure.
And this is a good point, because technically I talk about the neuroplasticity.
Exactly.
The capacity of the central nervous system to make change.
Yeah.
And we can think about that in a negative way when acute pain becomes a chronic pain. But also, you can think this in terms in a positive way.
You can change it.
You can change it.
So I think people never think about that.
Absolutely.
I think what happens is, and you see it too, and it happens to all of us personally, we start to live a life that, is pain. And, when I go and do this, I'm definitely going to have pain, right? So there's thinking around it. Then you stop the activities that give you happiness and dopamine and exercise and well-being. And you start down this path, and pain, and all the other biopsychosocial factors that you use that term, and people, are suffering, and they don't feel like they can change. But if they could change for the bad, you're absolutely right. They can change back, or they can make a new pattern, a new connection that doesn't have the pain.
Absolutely.
So that's something that I think people just don't know about,
And more and more, like this study showed to us the possibilities to make change. But at the same time, we know the complexity of these changes. Sometimes it's not only physical. Sometimes it's much beyond. Sometimes the style of life could be contributing for the change. For example, sleeping.
Okay. So
Let's
talk about that. Yeah.
We know, like, people that are not sleeping well, they have more chances to make a condition more chronic. So, okay, the medicine, the medications, all of them, they help conditions like this. But if patients don't make a change in their style of life, difficulty, they're going to change their situation.
Absolutely. So I did an episode on sleep that didn't even get into this. And what I wanted to say about this also that's fascinating is, not fascinating, but, when I see patients, I say, how does it interfere with your activities of daily living, and how does it affect your sleep? So for my shoulder, when I turned over to the right on the other side, I woke up with 10 out of 10 shooting excruciating pain 7 times a night. So that's obviously interrupting my sleep. That's making my brain hyperexcitable, which is not allowing for like glial cells to clean and prune and do all the things. There's more inflammation, and the cycle continues. So not only is their life being affected with, I can't go running that day, or I can't play soccer, but they're not going to sleep as well, and they're not going to get the other benefits of exercise. So how do you tell, lay people like me do you talk about that during your like intakes, or you're thinking about that, right? You're thinking about quality of life in general.
Yeah. I would say most of the case, it's not only talk about that, but you have to do a good evaluation and see how this is affecting patients in general. As you said, when you have pain, naturally, you try to protect yourself. Depending on the information that you receive, you're going to be in panic. You're going to be avoiding movements. If you see like some old approaches, for example, when you talk about herniated disc, that some providers, they show the spine for patients, show the disc over there, and explain in a wrong way that if they bend forward, they're going to tear the spine. This patient is going to be completely in panic to be moving, even to regular tasks, like, for example, to put their shoes on. This patient, and then becomes like a snowball in a negative way. They stop moving. They are not moving anymore. They get weaker. weaker, they get tighter, less movement, weaker. And like it's going to be a cycle, a negative cycle. My goal as a physical therapist after a good evaluation is what? Okay, no, you have to move.
Yeah.
We are human beings. You cannot stop moving. The worst approach is stop moving.
Yeah.
Depend on the situation. Okay, maybe some limited protection for a little bit, but little by little making progress, moving more and more. And then when the movement is better, what? Load the tissue with weights. With weights more and more, increase the body capacity. In a certain
So that's
moment,
essential. So basically, once you get your range of motion back, it's essential to...
or mobility or stability.
Yeah.
For me, this is basic. You have to work in what's wrong. The mobility or the stability? Okay, there's no stability and the mobility is bad. Okay, let's improve the mobility. Then let's make the tissues, the joints more stable. And then little by little, you stress the tissues with weights. To what? To increase the body capacity to a point that's going to be beyond the demands, the daily demands.
Bending over. So
Bending over,
so you're
carrying
loading
weights.
it. Okay.
Carrying. Okay, you have to carry a grocery bag. Okay, how much pounds is a grocery bag? 10 pounds? Great, let's lift 20 pounds. It's going to be an easier task.
The kettlebell carrying.
That's the point.
The gym.
Okay,
Yep.
there you go.
Yeah.
Okay.
That's amazing. That's amazing. I think the international community thinks about some of these things differently. Also, again, insurance companies dictate a lot of what happens in the US here. There's a certain amount of time, there's a certain amount of exercises they can do. And I think we don't get to think about this in the same way.
It's interesting, just one more extra information here, that recently, pain always was secondary to some injury. But since 2019, the World Health Organization considers that pain could be primary. Certain situations is the pain by itself.
Yeah.
Then it's a completely different situation. Situations like this, for example, migraines, for example, other fibromyalgia, the pain is not only a symptom, but the pain is the disease.
It's primary.
Yeah.
So I'm a neurologist with a migraine and headache subspecialty. So when I'm explaining this to patients, they don't always understand this. So a primary pain syndrome is something that doesn't have a secondary cause to blame it on. Okay. So for example, when patients come in with terrible migraines, also a very bad headache. I don't know if you've had migraines. I get them. They're horrible. People go to the ER because they think they're going to die and they think they have an aneurysm, God forbid. They think they have a tumor, and people come in here. They've had these things that are classic symptoms. They are convinced they have something horrible. And we do the scans, we do things to convince, to tell them that they don't. And it's so hard to understand that this is there's no cause. There's no cause. They're like, but I just want to know the cause so I can get to the root of it. That is the multi-billion-dollar question. There is no cause that we know about. And I don't know that we're going to be able to find that cause. Honestly, I don't know if we're going to have an answer for that. Yeah. But these primary pain syndromes that you mentioned, and I see a lot of migraine, fibromyalgia, even some of the arthritises are now considered. Even though there is joint wear and tear and some people have autoimmune, there is pain that we can't explain. And I have patients, I did a lot of chronic pain that have terrible abdominal pain. They've had scans, everything. There's nothing there. The way that you actually are able to get these concepts together is amazing. Yeah. And I think, it's amazing that you actually tell your patients this too, like that you tell them, this is what's happening, and this is what, potentially could happen. Yeah, it's going to be pain. So one of my favorite things that you do, because we have to wrap up soon, is that, when I lift up something very heavy, that's not so heavy, let's be honest, because I'm a little bit of a wimp, I tell you it's hard, and your response is always, whenever I say something's hard,
let's do it.
Let's do it, first of all. Yeah. And also that life is hard. So life... This is pretty much what he says all the time, right? Life is hard, and I think it is hard. I think maybe
nothing is easy. Nothing is easy.
What's easy?
Nothing. Forget about that. There is no easy life. Forget about that. There's no miracles.
You're right.
And I can tell you, We can make the miracles.
But we have to watch out for them, I think.
You can make your miracles.
Yeah.
You don't have to wait like some power or energy or whatever to bring these change you wish. You can make it.
Yes.
It
So we
depends
can
on
use
you.
some of the tools, we can use some of the medicines, we can do tests, but honestly, I totally agree with you as a medical doctor. For the majority of things that like chronic pain and headaches, it's hard. It's definitely hard. I'm not taking that away. It's very hard. And I'm so glad we have these tests and these medicines to do all these things, but we have to move through it and work through it.
How you deal with that? How is your position facing these problems? Is a problem? Yes, but you can make change.
Yeah.
You can improve your quality of life just facing the problem and try to go through it. Try to make your life better, period. If you feel like you are always you are a problem, then it's an excuse to not be working well, not to be a good family, not to be like points in your life because of your condition. Forget about it.
Yeah.
It's going to be hard to change.
Yeah. Amazing.
For example, I have patients, they have a chronic situation that has to be worked in their brain.
Oh, it's
Not
a brain issue.
It's not a brain issue. It's a central nervous issue.
It's
where we don't know. We don't know if it's on the spine. We don't know if it's on the brain. We don't know where. We don't know if the body is sending too much pain or if it's not reducing the pain. We don't know exactly. But the point is, based on old approaches, patients like this, sometimes they go to surgeries.
Yeah. They get scanned.
Believing that they have a solution for the problem, but unfortunately not. And when they come back from the surgery, now they still with the problem plus a surgery.
Yeah.
Then the problem is going to be much
They get
worse.
exploratory laparoscopy. You've heard about that where they go in microscopically. Exploratory.
Yeah.
They're doing a surgery, and listen, I don't fault them. They're looking. They're exploring to look for something. And they come in and say, and listen, I don't fault them because they are looking and these people are suffering, but they'll come in and say there was some debris around the joint, or if it's abdominal, they'll say there's scars. They see something with scars. But again, we don't know that that's.
They are always looking for a cause for the pain, but sometimes there's no
It's so
cause.
interesting. Two things. First of all, like with yoga, that comes up a lot. Like you can do something that you don't think you can do, but then your mind tells you can.
Yeah.
Even though your body's like, oh, it hurts, stuck.
But the pain's true. The pain's there.
The pain is real.
The pain's real.
The pain is real.
But the point is, the pain's not coming from the
periphery.
Okay, so that's number one. And then number two, it's like, I like massaging people. I don't have like a thing for it. I didn't go to school or anything, but I can listen to where the body's yelling.
Too.
Sometimes I'll touch something or a person will say, it hurts me here.
Yeah.
But I'll start touching here and there's nothing really here. It's here.
Mm-hmm.
And then I'll do this and the person will go, ow.
I actually wanted to talk. I wanted to bring that up after at the end. Remember when I said I had pain here and you said, and I was like, oh, it's carpal tunnel. And you said no. And you came and it was up here and it's a tight muscle.
This is physical.
Yeah.
Pretty much physical. It's over there. A good evaluation shows me that. But and this is not a big deal. The problem is the way some medical doctors are approaching situations like this. They are looking for through the picture something is broken.
Not holistic.
But look, she's not 12 years anymore. She's not 15 years anymore. She's using her hands.
Yeah.
She's doing activities. You believe that the shoe is going to be 100% perfect? No. And if you're doing all right, you're going to find something. Is this the cause of the problem, the real one?
I don't know.
Probably not. That's why a good evaluation is important. The same as the hernia disc.
Yeah.
You sit down 12 hours a day. You don't do exercise. Your muscles are weak. Everything is weak. You stand, go to the grocery, bend over here to get a grocery bag. Boom, have the pain.
Yeah.
Okay. Where are you gonna go?
Well, what you do, you sat for the last 3 hours.
You go to take a picture over there. You have 48 years old, 50 years old. The disc is broken, but it was before.
It was before.
Because you are human being, you move, it's normal. Your body is adapted to that.
That's exactly what we want to hear, honestly. Like how it's like every day a human you're going to be sitting down for the X amount of hours.
Yeah.
At the end of the day, if you're going to go do this, you're going to hurt yourself.
Exactly.
And people don't think like that. So that's a big priority.
I want to put in. We kept
Yeah,
rolling.
we're still rolling because like we wanted to break you
actually I
guys
want.
down. Yeah.
When you go to the grocery and you bend, you feel sudden pain,
Yeah.
but really it's not.
Yeah.
It happened to me. I can tell you, it happened once to me.
Everybody. It's everyone.
No, I can tell you, my experience, it's amazing. This is experience nice to share here with people because like I was at the clinic and my patient came. When he came, I bent to open the cabinet. When I opened the cabinet, I have the most excruciating pain in my life. I can tell you, I heard the pop on my back.
Jeez.
It was insane. I could not stand. My patient here in front of me. For 5 seconds, I heard all my patients talk about the back, the NADs, the back pop. And I said, oh my God, for 5 seconds. But then after 5 seconds, I said, hold on, nothing happened. I just bent here. A lot of pain. Between 0 and 10 was 9.5. I talked to my patient. He said, man, I am feeling the most excruciating pain in my back, but okay, let's do it. We're still doing the physical therapy. I tried to stretch myself. At that time, this was 2 years ago, I was practicing for New York City Marathon. I was 1 month before the marathon. So my training was the highest level. My body was very tired of training. And okay, so I knew about that. So I stretched a little bit. I went home, 9.5 of pain that day. On the next day in the morning, I woke up. My pain was 9.2. I had a training, 1.5 hours for the marathon. What should I do? Rest or go to train? Go to train. 1.5 hours? Of course no. For 30 minutes, light. But I'm going to move because I know it's going to be beneficial for me. I went for 30 minutes to run. When I come back from my running, my pain 9.5 was 7.5. I stretch a little bit. I released myself a little bit here. I press some trigger points on my back. I roll.
So you did more like restorative.
No, I move. I move. I just move. I just showed my brain that I wasn't in problem.
So it's really all a mindset.
That's
what I'm
it's
saying.
a mindset.
Like,
but this
as
is
an athlete,
this is a neuroscience.
Yeah.
The neuroscience shows us that the body put us in a kind of lock to protect us. But of course, I am a physical therapist. The point is, on the next day, this was Monday, on Wednesday, I stretched myself, I keep moving. Wednesday, I went to another training. On Friday, I had the third training. My pain from Monday, 9.5 was 1.
Question.
Friday.
Do you think we're giving too much attention to feelings, like the way we're feeling? Like I don't feel like doing it?
I cannot ask this for my patients because...
No, but I'm asking
the point is, I understand that patients and regular people, they don't know that. They look for providers that have give them this direction.
Yeah, but that's my question. My question is, if I am coming to you, would you tell me? Would you tell me like, hey, you're giving too much attention to your feelings. You can do this. You're capable.
Depends on my evaluation. If I see my evaluation, you had a problem, I'm going to refer you to a specialist and said, okay, look for a specialist because probably you tear yourself, but okay, let's make sure with the specialist what's wrong with you and then let's move on. The point is, most of the patients that come into me with some diagnosis, it's a wrong diagnosis. And they are in a loop because they are trying to protect themselves from wrong informations they are receiving.
They're also focusing on an anatomic
and that's the point.
Like issue that's it's been there for a long, just like all the things you said, it's been there for a long time. It's there is something anatomically, it's wear and tear. It's essentially wear and tear.
British Medical Journal released a paper 2017, I think, saying that low back pain, like mine, this case, my example here, it's not a case for MRI. Yeah. Because MRI is going to be showing change over there.
Stop that.
The point is, 100% of patients that I receive coming in general, they came from MRI. And they have like a wrong
frame. So their mind frame is already like there's something. So that's, you see, to me, this is very much what's happening in the mental health space. People are telling people, you have ADHD or you have whatever. Now you have a diagnosis. So now every treatment that comes afterwards is just to treat this tiny little ADHD. But it's not ADHD. You have a bigger problem. You're using it.
It's much beyond.
Yeah.
Yeah.
So I feel like that's the same thing with physical therapy. It's not this. It's all of this. Very cool.
That's what's
If you
supposed
have
to
the
be.
time,
Unfortunately, a lot of providers is still looking for that little thing instead to be looking for the big picture and be able to do tests on patients that make them secure what they're
so you
talking
have to
about.
reassure. So
Yeah.
I agree with that. And every once in a while you find something terrible, and that, unfortunately, as a provider, and the way that litigation is in the U.S. here, we have to do things.
That's the
But
point.
I can tell you that people do feel better when they know they don't have a brain tumor or, some big disc that needs to be, they feel better. They're like, okay, I don't have this thing that needs to be operated on.
Neck pain. Just a conversation with my patients here.
Yeah.
I know it's a red flag for it.
Yeah.
And then I'm going to send them to a specialist.
Yeah.
And of course,
Same.
let's go
Same.
deeper. But depending on what they talk to me, they don't have pain at night. They don't have a constant pain. They have pain by the end of the day after work a lot. Is a brain tumor? Maybe not. When expose patient like this to a MRI, that is a lot of radiation.
So I'm going to correct you on that real quick. So the MRI, because they're always worried about that. So MRIs don't have radiation, but they cost a lot.
Yeah.
They have to go do it.
Is a stress
They-
to be
it's a
inside that
stress.
machine?
They stress out, and we see more incidental things, just like you
Yeah,
said,
yeah.
all the time. And it's just, and I agree with you. The problem is people are conditioned to wanting to see inside and get the scan.
And
But
if-
I agree with you.
And if you go deeper in this conversation, I talk even in terms of costs of treatment that make the costs of treatment much more expensive.
Yeah.
For insurance, for everybody, for all the providers, for everybody.
Yeah.
So I think that we have ways based on science to treat our patients that's going to be safe for them and much more effective than most of providers are.
And they have to wait for it, and then they go and they do rest, which means nothing for like 10 days with some medicine.
That makes sometimes it
When
was
in fact,
even worse.
in fact, the data shows, like, for low back pain, the best thing, walking.
No, I can
That's the best thing. When you look at the studies, that's it.
I compare
It's not
myself
any of the other
to
stuff.
the patients. Myself, when I had the pain on my back from Monday to Friday, my pain went away, and I keep training for marathon. I finished my marathon a month later. If I wasn't a physical therapist, I'm sure
Yeah, you would have
I
stopped.
was in trouble
Mm-hmm.
because instead to treat myself, I would go to the hospital.
Worse, yeah.
They're soccer players, and their knee is constantly going. So, what do we do for those people?
Yeah, actually, sometimes there's a tear on tissues. Of course, you have situations that they are like an ankle sprain, a knee sprain, a ligament sprain. We have to heal these tissues. But the point is, you have like natural phases of healing. You have inflammation. Okay, this point of inflammation, you have a lot of pain. It's normal. The body is trying to protect you to get even more injured. So this inflammation, you have signals of this inflammation, but little by little, the body is going to be healing. As a physical therapist, I will make sure that the healing process is going to be the best as possible. Avoid some limitations of the body, because hurts, naturally you try to limit yourself, but let's try to do the healing process as best as possible.
It's a circuit happening over and over again, but it's a primary pain syndrome. And that thinking is harder to treat. It's harder to target. Thankfully, we have more medicines now, but I think a lot of secondary pain syndromes, so like low back pain, become primary. Not like primary, they started with something. Someone did, they blew out a disc, let's say, it healed, and then it was weak, and then they did it again, and then slowly over time, they have pain every day. And then, yes, there was an original cause, but they can have back surgery, they can do certain things, and if they don't do the things that you said, and they don't address sleep, and they don't address, life, it's going to continue. There's a chance it's going to continue. And I think people, are scared of that. But also, it's very hard to wrap your head around, I had this tear in my shoulder, or I have a disc, and I have to work through pain. So how do you talk to people about that? How do you tell people, yeah, you're going to have excruciating pain when you bend over, and it's going to shoot down your leg, but it's going to be the worst thing, but we have to work through it.
That's a great question, great point. And I believe that patients like this first think education pain. They have to understand what's the pain.
Yeah.
The pain is not only a mechanism, a body mechanism. It's not because you have a tear that hurts. No, it's much more complex. And this complexity, you have to teach them. For example, giving them examples that the pain depends on your conception about the pain. So if you have a conception that when you move and you have the pain, you're going to be injuring yourself
further.
Yeah.
Or just again. Yes.
You're going to be naturally stopping moving.
Yeah. Yeah.
But it's not like
it's like a trauma. It's like you're repeating it. I'm going to go through this pain and so you're not going to do it.
Exactly.
But maybe you have to a little bit, right?
The point is you have to teach them that, okay, maybe you have some there, maybe the pictures are showing something, but listen, you don't have to be protecting all the time. If you have some pain during some movement, okay, it's okay. We're going to respect this pain, but let's try to go more and more, beyond and beyond. Let's be feeling more confident about there, and let's move. And naturally, these connections the central nervous system is making, that is showing you the pain, little by little, it's going to be adapting to the movement, and you feel less and less.
Less and less and less time. Yeah. So it'll be like, you'll have it maybe for a day, and then it'll creep down, and then you learn again.
For these patients, like as a primary pain, as a primary condition, the studies showing that like exercise are very important.
Yeah.
To keep them moving, to keep them like avoiding this to be sedentary. Yeah. We know that sedentary, it's a great risk factor to pain.
Yeah.
So when they start feeling the pain, when they have the pain condition, they avoid exercise.
Yeah.
And
which is what they need.
Yeah.
Yeah.
And they make the problem even worse.
Yeah. And let's not even talk about how that becomes disability, and then you don't go to work, you don't do your activities, you don't hang out socially, you get depressed, you don't sleep because of that. It's a really vicious cycle.
Exactly. Other patients, like a herniated disc patients, sometimes the disc is there, but it's not the cause of the problem. That's unfortunately very common. When you do tests on them, clinical tests, we know that although the disc is there and the MRI showed, but the problem is other problems. Sometimes it's the ankle problem. Sometimes they have like an ankle, lack of mobility on the ankle. When they bend down, when they go down like a squat, they are compensated on the back. When you look at the back's really tight. So, okay, the disc is there, but is the real problem the disc? And we try to teach them, to show them this situation, of course, after a good evaluation. And then they get more and more confident, they move more and more, and feel better and better. And then we are able to push more and more.
Well, Luciano, I think we're going to have to do more shows, because we didn't even talk about, what we talk about with training. And I think you have amazing ideas and an amazing attitude, which is so refreshing. And I really appreciate you being on here. Is there somewhere that people can find you? There's some, what is your business name, or the way or just by your name, right?
Actually, it's my name, Luciano Rossi.
Okay.
Definitely, if you have some way to provide my contacts and my Instagram,
what's your Instagram?
My Instagram is Luciano Rossi Physical Therapy. But I can't change. I don't remember well, but
we're going to provide.
Yeah, I provide it later. But definitely, what I'm trying to bring is a change of paradigms based on science.
I love it.
The science is changing very fast. If you keep connect to old approaches, forget about it. I think it's going to be hard to make change in the life of our patients. The best is be evidence-based, look for the change that the science is bringing for us, and to provide the best treatment for our patients.
Well, I'm so glad we met. And thank you for being on the show.
My pleasure.